So thank you everybody for joining us today for the latest in our webinar series, Solutions to the Opioid Crisis. So today we're going to talk about best practices and what our patients need from us to do to provide best practices on substance use disorder. So greetings everyone, my name is Dr. Kendall Portalieu and I am the statewide director of data analytics and strategy for Project Opioid, and I'm also an associate professor at the University of Central Florida, where my area of research is healthcare informatics. So I'm so excited to be here today to talk to you guys just a little bit to get started about what Project Opioid is and why we're having this webinar series and why we're doing what we're doing. So Project Opioid is a coalition of business, faith, and philanthropic leaders that are working together to really combine and address the opioid crisis in our communities. So what we're really doing is bringing together people that aren't usually in the space of healthcare and bring them into opioids. We're really trying to help them understand what is going on in their community and help them make a difference. So if you look at our little diagram here, you can see the people in red. They're not usually involved in public health, right? We don't usually have business leaders, the CEOs of these very large organizations, faith leaders, philanthropic leaders. But what Project Opioid is doing is bringing those people to the table in order to help them reduce stigma in their organizations, in order to help bridge the gap and really get to people before they lose a lot of their social capital and a lot of the negative consequences that happen when individuals are addicted to substances. So I think it pretty much goes without saying to this crowd that COVID-19 has significantly impacted the mental and substance abuse that's going on in our country and across the state of Florida. So Project Opioid started in 2018 before the COVID-19 pandemic, but really since the COVID-19 pandemic, we have seen our mission grow and we have seen the need really expand to bring education and to bring information to organizations and to individuals across different communities on what they can do to help impact individuals in their communities. So I want to start by giving a big thank you to our educational series sponsors. And those sponsors are Central Florida Cares Health Systems, LSF Health Systems, and the Southeast Florida Behavioral Health Network. Without these three managing entities, these educational series and these webinars would not be possible. So a huge thank you to our managing entities for helping us to reach out to providers just like you guys today to help educate and help you understand what you can do to impact this crisis in your community. So our educational series is coming to a close. Our webinar series has been going on all month, but if you missed any of them, we've got all 9 of them available on projectopioid.org. I highly encourage you to go to our website and watch a lot of them. Dr. Carbiner and Dr. Roll are 2 of our guests for today, and they have been in several webinars, so I think you'll find them very, very interesting. So please go and take a look and watch those and let us know if you have any questions. So without further ado, I'm going to do a quick introduction of our panelists, and then I'll let them introduce themselves as well. So we've got 3 individuals to speak with you today. The first is Dr. Pamela Carbiner, who is an OBGYN in Volusia County, and she's going to speak first about SBIRT and about ways that physicians can help impact their patients in a positive way using a very easy technique. Then we have Captain Cornelius Blue, who's going to talk to us about the impact of COVID-19 and opioids on vulnerable population. And then Dr. Aaron Wohl, who is with the Orlando Veterans Medical Center and is the medical director of Project Opioid, and he's going to speak with us about hospital bridge programs. So Dr. Carbiner, would you like to go ahead and get started? You're on mute.
Yeah, there we go.
So,
yeah, good morning, and I want to thank Kendall and Project Opioid for the opportunity to get information out to as many as possible. Like Kendall said, this crisis has been ongoing now for over a decade, but COVID has accelerated the needs of our community. And I like to say that this is not an epidemic of any particular substance as much as it's an epidemic of despair. And the ability to bring businesses to the table and reduce stigma. And I loved your sentence, Kendall, about avoiding the loss of social capital, because without the wraparound, without this infrastructure that people have, it's very difficult for them to recover. And if they lose all of that in their disease process, it's much harder to succeed than if we get it before it gets to that point. And since COVID has started, we have seen many more young women lose their jobs, lose their homes, lose their social capital, while we're trying to address the issues of substance use disorder and pregnancy, and basically the risks of sheltering, losing their babies, looking for reunification afterwards. Obstetricians have a wonderful opportunity in this particularly vulnerable population to identify those women who are at risk. And historically, women who have had concerns with opioid use disorder or substance use have been very reticent to give that information to their OBGYNs. They fear that they will be let go from the practice, that there'll be recrimination, judgment, that social services will take their baby. What they need to realize is disclosure to a safe space and subsequent care is going to increase the chance of success and not having their babies sheltered from them or their lives completely taken apart by opioid use disorder. So ESPER is a wonderful way to think about evaluating all patients, identifying those who are at risk, and then doing a brief intervention and referring them to treatment. And there is a wonderful short video that I'd like everybody to watch. It has one of my colleagues, Dr. Lanowet from USF, has the primary speaker for this project. The Florida Perinatal Quality Collaborative has an initiative called MORE, basically maternal opioid recovery effort. And this is one of the many videos that we have on our website to help people understand how to go about identifying and helping women with opioid use disorder. So Kendall, if we could just run that video, that would be awesome.
Great, absolutely.
Yeah, it's a short video, but it's very, very helpful.
There we go.
Okay. Dr. Lanowet is an excellent.
Dan Lanowet. I want to introduce you to the Florida Perinatal Quality Collaborative Maternal Opioid Recovery Effort. WHO, ACOG, the American Medical Association, the American Academy of Pediatrics, and the CDC all recommend universal screening for substance use in pregnant women. The faces of opioid use disorder really mirror our own faces. Opioid use disorder affects all ages and races, all economic and social strata, and all levels of education. Opioid addiction crosses all boundaries of race, sex, and socioeconomic status. This graphic represents the racial makeup of suspected drug overdoses in Florida in 2018. Identification of women with opioid use disorder early in pregnancy has been shown to improve maternal and infant outcomes. Anything other than universal screening can lead to missed cases and may add to stereotyping and stigma. Many women with opioid use disorder are fearful of sharing with obstetric providers because of past negative experiences and concerns about being separated from their newborn. We must create a safe and open atmosphere in which to screen. Screening should be done via a validated verbal or written screening tool. Several are recommended by ACOG. Universal screening with urine drug screens is controversial. It assesses only for current or recent use. A positive test is not diagnostic of opioid use disorder, and a negative test does not rule it out. Finally, urine drug screens may not detect many substances, such as some synthetic opioids, which are increasingly being used. Women with opioid use disorder are 7 times more likely to forego prenatal care. This is in large part related to past experiences with healthcare. When women face stigma in the health system, it reduces the quality of care they receive. It also makes the person less likely to follow through on a treatment program out of fear that they will face stigma again. It is important that we all monitor ourselves, reducing negative attitudes towards women who suffer from opioid use disorder, their friends, and family members. We have to be vigilant about the use of negative labels in everyday conversation. There are several tips for effective screening tool implementation. First, reassure the patient that these are universally asked questions and that she is not being targeted. Assure the patient that these answers are confidential and will be shared only with her healthcare providers. Ask the questions in a non-judgmental way and try to create a safe space for the patient to volunteer information. An example of an easy screening tool that has been validated for use for pregnant women is the 5 Ps. These 5 quick questions can identify women with opioid use disorder or those at risk. After women complete the questions, any positive answers should be followed by a short conversation with a provider. This is the backside of the FPQC pocket card that can be used to guide the brief intervention. Positive reinforcement should be given for disclosing the information. Women may feel that they're taking a risk by answering truthfully, and it is important to reinforce that they're doing the best thing for their own health care and the health of their baby by disclosing the information. An attempt should then be made to gauge the woman's willingness to engage in treatment. A plan of care can then be negotiated with the patient. If the woman is not ready for intervention, attempts can be made to assess any change in all future visits. All women with a positive screen should be offered a prescription for naloxone and instructed in its use. The importance of providing referral for all facets of treatment cannot be stressed enough, and lists of local referral networks should be readily available. Psychiatric disorders are more common in women with opioid use disorder, 30 to 40% having a diagnosis of clinical depression. This places them at increased risk for postpartum depression, so support services are essential. In addition, psychiatric comorbidities are independent predictors for more severe postoperative pain. The Department of Health and Human Services strongly encourages OBGYNs to provide buprenorphine treatment for women with opioid use disorders. The first step in providing medication-assisted treatment is to obtain a Drug Abuse Treatment Act of 2000 waiver to existing controlled substance prescribing requirements. Only about 5% of US physicians currently have a waiver, severely limiting care for those who need it. There is also a movement suggesting that all OBGYN trainees graduate equipped to provide medication-assisted treatment with their patients with opioid use disorder. Postpartum contact should always assess for signs and symptoms of postpartum depression. In addition to addressing mental health issues at every opportunity, patients will also need support to be able to care for family and continue their own care, such as medically assisted treatment. Following through on family planning desires is also critical. Rates of unintended pregnancy in women with opioid use disorder have been found to be about 80%, considerably higher than the general population, which is 30 to 45%. Thank you for watching this video and for wanting to do more for your patients.
So I think that is a very helpful introduction to SBIRT. A couple of things I want to add is that this year, the mandatory waiver for buprenorphine administration has been removed for physicians, MDs, and DOs who are willing to treat 30 or less patients. However, we do strongly recommend that the 8-hour course or something comparable to that still be taken, because it will give you a sense of comfort and tell you what pitfalls to avoid. Treatment cannot be simply medicine. It has to be therapy and wraparound services. And when you look at the issue of SBIRT, screening, brief intervention, That's what we're talking about for the primary care physician or the obstetrician who has not thought about becoming available to treat addiction in their practices. That means that referral to treatment must be available. And each individual community is going to have different challenges and different strengths in that area. And one of the efforts that the FPQC is making is to try and identify county by county what is available. And we encourage people to work on that as individuals. Also learn about what's in your county in terms of Healthy Start, in terms of Medicaid approved targeted case management, in terms of what DCF and child protection in your communities has available for you. Are there residential treatment centers? What does your hospital have? And getting to know these things so that you're comfortable with referral makes it much easier to then do the screening and brief intervention. What else, Kendall, do you think? Is that enough right now so that we can allow Dr. Wall and Captain Blue to have access to the physicians? Oh.
Are patients open to discussing their substance use? Have you gotten pushback from people that don't want to be asked?
Rarely. And I think that's because, at least in our community, it's well known that I'm not going to be judgmental and that I'm very interested in helping them where they are at.
Right.
I encourage all of my medical students and residents and my peers to use the 5 Ps, because the 5 Ps is very easy to use and it can be done in a non-judgmental way. Like Dr. Lanowitz said, I usually start out saying, in the very first new OB visit, in the world we live in right now, it's important for us to be able to help all patients, whatever their struggles are. And this 5-question interview is to just help me understand if you have any other issues. And it's remarkable how many people, if they are not having current issues, have had past issues and welcome the discussion because they're concerned about becoming at risk and relapsing.
Right.
And are there going to be people that withhold? Absolutely. But at least you're getting the conversation started, and they will have a sense that they can maybe bring up more in the future if they need to. And at one point, my practice did do biologic screening on everybody, as controversial it is. Volusia has very high incidence of opioid use disorder in pregnancy. But we actually have stopped doing that because we found that the 5 Ps were much more accurate and much more helpful for beginning the discussion and continuing to build that relationship during the pregnancy.
Interesting. And I know that time with patients is always a challenge. I mean, you said this morning you've already seen 25 patients today. So how long does it take to do the SBIRT?
It really is just a couple of minutes.
Yeah.
Unless you feel that there is an acute situation that needs immediate intervention. And then, yes, it may cause your schedule to get backed up. But that is why we're here.
Right.
And I think people understand in an obstetrician office better than most, we're not always able to continue our schedule as we hoped to.
Yeah, I'm sure that is very true. So besides obstetricians, what other providers should consider using SBIRT in their practices?
I think Dr. Wall would agree with me that I think there isn't a practice that shouldn't be aware of this. I think if every practice looked at the opportunity when a patient comes in for their specialty as an opportunity to help the holistic part of the whole human being, we would have all practices evaluating people, just like we can do now for blood pressure. Everybody takes a blood pressure. And if it's elevated, we talk about that to the patient. I think obviously primary care should be doing it. I think that orthopedics, certainly neurology, psychiatry, that's obvious. Internal medicine, endocrine. I don't think there's a practice out there. Emergency rooms are already doing this in many places and are developing programs to help people at acute intervention. But there isn't a physician out there or mid-level practitioner that shouldn't take advantage of the opportunity to evaluate this and refer for treatment.
And do you know how common it is? Do you know how often it is used?
I know that we started out from a place of very minimal.
Right.
I know that physicians historically were not trained about this. This particular epidemic is very young. It's only been around for the last 15, 20 years. And many, if not most, of practicing physicians have not had exposure or comfort with this. And they're so busy with the other aspects of their practices, it's easy to avoid it. It's easy to have judgment, consider it a personality flaw, a character weakness, a decision made by people, instead of being a disease that deserves the treatment just like diabetes or hypertension. And I think those that are trying to increase care, they best serve these populations of providers by increasing their awareness, increasing availability to wraparound services, a training, and a treatment, so that either they can choose to provide treatment for their particular patients, or they can feel comfortable with referral to treatment and know that it'll be followed through.
Absolutely. And thank you so much, Dr. Carbiner. That's great information. I think this is a great segue to Dr. Wool. Just before we start talking about bridge programs, what's been your experiences with SBIRT in the emergency department?
Definitely, initially, I think there was a little bit of resistance to it. And I think that's an overwhelming theme that maybe Dr. Carbiner didn't say specifically. You had asked her a question about, how long does SBIRT take? And, my answer would be a few minutes, but it could be less than that if we changed our paradigm in our treatment environments, where we actually posted signs inviting patients to seek treatment. And what that does is when the patient comes to receive care, they have a lot less they feel less stigmatized, and then they can actually prompt it. So not only are physicians and nurses screening for it, but the patient can actually reach out and ask us. Also, one of the key words now associated around SBIRT is trauma-informed care. And what is trauma-informed care? Trauma-informed care is the realization that the medical environment, even the hospital bed and the gown, and getting them, asking a patient to strip down and put on a gown, it actually is contradictory to what the patient might have experienced previously. So we're not actually asking, what is the drug? Dr. Carbiner also alluded to this. We're asking, what is the trauma? Where is the pain coming from? And we've realized that a lot of times the environments that we set up to treat patients with actually create a little bit of stigma, and they actually can re-trigger trauma and somewhat avoid care. And so that's a very end-around way of answering your question, Dr. Cortelyou, that once we inform nurses, techs, nurses on the floor, hospitalists, once we post signs and inform our caregivers about how to engage patients with empathy and kindness surrounding this trauma-informed care, really it makes this screening process a lot more natural, and the flow is so much more easier.
I think that's a great point. And, trauma-informed care was not one of the topics of this webinar, but I think it's absolutely applicable and something that we definitely need to provide more education on. And so thank you for bringing that up. And especially after the pandemic, I think we can all agree that a lot of people were triggered and have certainly had some adverse events occur during the pandemic and have suffered some mental health problems, and certainly will have some long-term trauma from it as well. Well, I want to make sure that we get to talk about the bridge programs. So I know, Dr. Wool, that we have talked about your role in bringing MAT into the emergency departments, and it's been a huge success. All of the literature supports the fact that bringing this evidence-based practice into the emergency department really helps people with treatment. It increases how many people are getting into treatment, how long they stay into treatment. But as the practice has gained popularity across the country, I think we are seeing now that we have problems with the transition of care. So emergency department physicians and patients are often confronted with what's next. We've got 7 days of buprenorphine, a Suboxone prescription, but where are these patients going? How are they getting the long-term care that they need? And so I know that there are some grassroots in some areas and some better established programs to help people navigate the system. So can you tell us just a little bit about what a bridge program is?
Yeah, certainly. Just in the most easiest way to describe it, a bridge program is just what you said, which is we identify the patients through tools such as SBIRT in the treatment environment. And the reason I keep saying treatment environment is because I started this work 7 to 8 years ago promoting just emergency departments, but we're now trying to express that it's not only the emergency department, but the hospitalist environment. And what is a hospitalist? That's the physician that treats the patient as they're in the hospital on the hospital floors. And so since emergency departments and hospitals provide, 24/7 access to healthcare, they really offer a unique opportunity to make treatment for substance use disorder universally accessible and acceptable. In other words, non-stigmatized. And so, despite the evidence that you've mentioned, Dr. Carabiner's mentioned, there's this strong evidence that buprenorphine initiation in acute care, as well as guidance from emergency medicine societies and other professional societies, Dr. Carabiner mentioned all of them, as far as they apply to OBGYN patients, many hospitals still don't really offer this service. And what is that service? That is initiating treatment, making a connection to the outpatient treatment facility, and making sure that the patient is really handed off or shepherded to that treatment facility and watched very closely. And hopefully that connection is made within 24 hours. So this patient is not just discharged with a piece of paper that says, here's the treatment providers in your community. No, we're asking hospitals, emergency departments to hire a substance use navigator. That navigator basically is scheduled from 9 a.m. till 11 p.m., not necessarily the same person, of course. And during those times, that substance use navigator, after we do SBIRT, identify the patient and offer them treatment with medication for addiction treatment, such as buprenorphine, the substance use navigator goes in and connects that patient and makes sure that they have an appointment within the next 24 hours at these outpatient treatment facilities. You mentioned grassroots treatment programs. They're not even grassroots anymore. They are so robust and so dynamic that most of the stuff that I spew and spit out is completely copied. I say R&D, which is rip off and duplicate. And so basically, I look at the California Bridge program. If anybody on this call or this webinar just puts in cabridge.org, you're going to get this incredible website with all the information that I'm providing here. There's links to OBGYN services. There's links to patient signs that you can just copy and put up in your facility. There's information on trauma-informed care. There's even information on how to put out a application for a substance use navigator. So, hey, this is what we require. Can you please come and work for us as a substance use navigator? So they've provided all of the legwork and we don't have to reinvent the wheel. And I say it's not grassroots anymore because California as a state has adopted the California Bridge methodologies or protocols and said by 2025, they want to have all these treatment modalities available in every health care setting. And so really, again, the main three issues is with a bridge program is treatment, which is in the emergency department or on the hospital floors, connection, which is establishing pathways to link patients to that outpatient care through active support and follow-up. And then a big one, and we allude to this, but nobody comes out and says it with intellectual honesty, is culture. Treatment, connection, and culture. And what is culture? It's creating that welcoming, non-stigmatizing hospital culture for people who use drugs that's reflected in patients, facing communication issues throughout the hospital with an emphasis on building connections with empathy and building trust. So that's really the overall encompassing picture of what a bridge program looks like. In California, the emergency departments have even developed a wing of the hospital where they can actually send patients to right after they're seen in the emergency department. So they've created their own treatment facility as an outpatient. And these hospitals staff emergency physicians with board certification in addiction treatment, and they staff those outpatient treatment facilities so that the outpatient treatment is always available for the patient.
Wow, that's amazing. That sounds like an amazing program. So even if the programs aren't as robust as some of the ones that are in California, how effective are they?
Extraordinarily effective. They find that 65 to 70% of the patients that they engage stay in treatment within a year. And this is as opposed to what we have when there's no care available. And that is, again, 10% mortality when you have a patient who overdoses and they non-fatally overdoses. They come into a treatment facility such as an emergency department. When we discharge that patient, 10% mortality in 1 year. In other words, 1 out of 10 of the patients that you send out without care or connection to an outpatient facility is going to die within a year. I mean, that's abysmal, that's reprehensible, that's unethical. You know, we really are trying to sound an alarm to establish better care and connection for these patients.
That's a startling statistic for sure. I've heard you mention that before, and I know that there's so many people that want to do something, and maybe they can't do a program as robust as California, but there's different models of bridge programs. So what are some of the other ones that could be implemented around here, and what are some of the pros and cons of those?
Basically, when we started at our facility, you know, everybody says, well, you know, how do you eat an elephant? And we all say, you know, 1 bite at a time. And if you basically just start with a champion in your treatment facility, whoever's on the phone or this webinar right now that's interested, you know, can reach out to us and we can give them the materials to make them the champion in their facility. Find a few doctors who will write for buprenorphine and who agree to write for buprenorphine. Once you start it, you know, the hospital basically notices what's going on. The hospital, usually the C-suites are interested in treating this patient population because it's really good for the health of the community. It saves money, it saves readmissions, it diminishes cost, it diminishes illicit behavior, and it diminishes criminal behavior in the community as well, which is one of the reasons why we have law enforcement as one of our most robust partners. So what I'm getting at is just put one brick on top of the other. You do not have to have a perfect blueprint and a perfect model to build a home. You just start with one brick on top of the other. Again, develop a champion, involve your pharmacists, involve the nurses, involve your care management providers, your social workers, and then make a connection. I just reached and picked up a phone and had a very, very responsive treatment community provider who basically picked up the ball and ran with it. Really, you know, we handed the baton off to them. They started to essentially establish a substance use navigator via telehealth, if you will. And our social workers just called them. They made the appointment for the patient and the patient was discharged. Honestly, it was a little bit willy-nilly. It wasn't exactly perfect, but we weren't building a research program where we were just trying to save lives. And it really just starts with an individual and an individual champion.
That's great. And what role can peer support specialists play in that?
Peer support specialists are the absolute pinnacle of what we want. You know, if you had a substance use navigator and then a peer support specialist, the peer support specialist basically engages the patient so that you don't have to, we say when you educate a hospital system, you don't have to boil the whole ocean. In other words, you don't have to educate every single patient, nurse or staff member in the emergency department. You have a peer support specialist who's an expert in this kind of care, trauma-informed care, and can approach the patient and really provide for outpatient contact. When the patient has any trouble reaching that substance use provider as an outpatient, they can then rely on the peer support specialist to basically help them break down some of the barriers that they might have come across.
Yeah, that's a great point. And I do want to mention that we have had a couple of peer support specialists on some of our webinars that are available on projectopioid.org. If you go, I think that you'll find some really interesting discussion. They are such an integral part of the recovery for so many people and really can make a huge difference. So I think we've talked a lot about some of my other questions. You mentioned kind of the importance of the business case, right? If we can do these bridge programs, not only do people have a better long-term outlook on life, but we can keep people out of the emergency departments. We can keep people away from visiting Captain Blue, right? With the with law enforcement. And so what other positive impacts can these bridge programs have?
Well, they basically essentially express to the patient that there's a safe harbor for them through the healthcare community. Even outside of just making that connection, one thing I haven't mentioned, and which is very important to mention, is we talked about trauma-informed care, but I would also mention harm reduction strategies. And this is the fact that if the patient isn't amenable or doesn't want to receive medication for addiction treatment, you can at the very least educate them on harm reduction practices and give them naloxone. Naloxone is sort of the anchor of harm reduction strategies. But yes, our nurses and substance use navigators and our peer support specialists know how to talk to the patient with empathy and kindness and discuss with them their use. Can they diminish their injection practices? If they are going to inject safely. We teach them how to do that, try and get them supplies to do that. It's not a needle exchange program. This is just simply saying, hey, we care about you. We care about you as a human being. You're valuable to us and others in your life. And here's how to safely use, because we know you're going to walk out and use as soon as you're discharged if they're not on medications for addiction treatment. So, I did forget to mention that, and harm reduction is a huge part of this whole paradigm change.
Absolutely. Thank you for bringing that up. That is definitely a major point that we want to drive home, is the importance of harm reduction, because not everybody is ready to enter treatment. Not everybody that maybe shows up as having a problem with the SBIRT or comes in with an overdose is ready for treatment. So harm reduction is so important. So thank you for bringing that up, Dr. Wool. And thank you so much for the information on what could be a really impactful program that can be implemented across the state of Florida. So next, we're going to have a discussion about the changing face of, next slide, please, the changing face of the opioid crisis. So what we've really realized in looking at the data over the last year or so is that we've really seen a change in demographics surrounding the vulnerable populations for opioid crisis, as well as other areas, other deaths of despair. So today I'd like to welcome back Dr. Pamela Carbiner, and I would like to welcome Captain Cornelius Blue. Hi, Captain Blue, how are you?
Great, how are you all?
Wonderful. Thank you so much for joining us. Captain Blue is a captain with the Seminole County Sheriff's Office and also a pastor locally here in Orlando. And so he brings a really great and unique perspective to this issue, and especially to how the African-American and Hispanic populations are being impacted by the opioid crisis. So we're just going to talk for a little bit about what you've seen and what you've seen in terms of the changing demographics. So Captain Blue, why don't you go ahead?
Well, I'd like to say, first off, thank you for having me. It's definitely an honor to just represent not only some kind of Sheriff's Office, but also every citizen of Seminole County in this discussion that is extremely important. In regards to your question, I think we all realize now that this touches every single boundary that we thought we had in place to prevent this from happening. And as mentioned before, with the pandemic taking place, we've seen an uptick in overdose cases, families that are being affected in a harsh way by this. Several people, unfortunately, have lost their lives to this cause. And I can tell you, this has really shown us that it's not prejudice. And a lot of people have really found themselves in a bad spot. And we've responded to numerous of calls where it ranges from a person that's homeless to a person that is struggling at home or at school, and they're asking for assistance and crying out for help. And of course, we do our best to provide whatever services are possible. And even through the faith-based community, there have been a ton of discussion amongst clergymen from all walks to figure out how can we provide tools that will educate parishioners, families, etc., to be preventive and not allowing this epidemic to reach beyond what we're seeing right now. So we've seen a range from age groups, unfortunately, both young and old, as well as various ethnicities. So it doesn't, as we know, it doesn't have any prejudices to it. And that's what's dangerous really about this problem we're seeing, and just a lack of education that folks that, I remember the time when I was a kid that my grandmother, if I sprung an ankle, would say, hey, go in the house and grab this and you'll be fine. And I've seen cases now where, now that I'm more educated about the issue, where identified as a problem. And unfortunately, a lot of folks just don't know any better. They're not educated, and they look for those keywords like such as heroin or some street drug before they realize the problem, not realizing that even the prescribed medication is also an issue.
Absolutely. And thank you so much for bringing it up, that this is really has no boundaries. And as we talk to these providers today, I think the reason that we wanted to have you on, Captain Blue, to talk about the changing face is that the person that's sitting in your office might not be the person that you would have traditionally thought would have an opioid problem, but the face of the crisis has changed. And so thank you so much for that insight. This question is for Dr. Carbiner. By the numbers, how are women and children impacted by the opioid crisis? I think you're on mute.
There we go.
There you go.
I don't have numbers for 2020 or 2021. I can talk more about increase. We are seeing in the state of Florida upwards of 5 to 10% of all pregnancies will relate the use of opioids during their pregnancy or just before. And if you think about that in terms of how many people are affected by that, there's not hardly a woman or a child out there who doesn't have a cousin, a friend, a mother, a daughter, a peer, an employee that is directly affected by this. We are seeing our foster system completely overwhelmed because we have removed so many children due to the belief that the parents are not able to take care of them, directly related to their substance use disorder. And we are trying to get better at that and recognizing helping the family as opposed to sheltering the child is our goal. And that is with working with law enforcement and the judicial system and the child protection system. I would have to say that in my practice, and basically I do tend to be a magnet for people who have these issues. 1 out of every 5 to 6 of my pregnancies at this time is somebody who I'm treating for substance use addiction.
Wow. That is a startling number. That's really impactful.
That is my, my specialty,
right.
But still is remarkable.
Right.
Yeah, I think it's even, that's a startling figure, but as Dr. Carabiner is saying, she's specialized in that. So she's sort of has a bias.
Right.
But I believe that the numbers of opioid use during pregnancy is pretty common. It's considered in general, just out anywhere, just pick a pregnant female, 6 per 1,000 live births are essentially suffering from opioid use disorder. And again, medication assisted treatment can normalize this condition.
And I would say, Aaron, that that's probably very much of an underestimate because, people still are unwilling to disclose to their physicians.
Good
And
point.
they could be on methadone or medication that if the delivery is uneventful, they can get out of the hospital with their child before there is any apparent symptoms in that child. And if the system is not actively looking for it, that can be a child that is born and goes home and then starts to have withdrawal in a home environment that is already very stressful. And that puts that baby at an increased risk for abuse. I will say that with maintenance therapy, like buprenorphine, if these patients disclose, obtain treatment, and at birth, let the DCF and the child protection system know that they have a plan of safe care, know that they're working with a physician, obtaining medication-based treatment, maintaining the child-parent dyad is the goal. And these people do go home with their children, and we focus on maintaining their health and well-being for the years to come.
So Dr. Carbiner, what can physicians or providers that are on this call do to help women feel comfortable disclosing? SBIRT is the way that I would go about it, but you start out with, your new patient here, congratulations on your pregnancy. It's wonderful that you're coming for prenatal care. It's critically important for the health and well-being of your baby. One of the things we talk about besides genetics and how, what to eat and what things to avoid is risk factors in your life that could impact the health of you and your baby. Mm-hmm. And one of those in our culture and society right now is exposure to substances. We're under such stress economically, socially, with families, that many people are treating despair, treating depression, treating pain on their own. And these medications then take a life of their own. And if you have any concerns with this, either your own concern, your partner's concern, a parent, you in the past, all these issues are important for us to discuss so that we can optimize your care. And then you can go into the 5 Ps. Right. And really you can almost sense a sigh of relief when that comes up, because patients don't want to be pregnant and keeping information from their doctors. Mm-hmm. They didn't grow up thinking they wanted to be pregnant and addicted. They don't want to have the stress of hiding this. They don't want to have the stress of thinking their child is going to be taken away from them. Early intervention is going to greatly increase the chances of them being able to keep that child and that child being born healthy under the best of circumstances, doing harm reduction, like Aaron said. And all physicians need to be part of this. All obstetricians, all people taking care of humans. Right. Absolutely. I think that's a great point. I mean, your job is not to be the police. Your job is to help them grow the best baby that they can and deliver a successful, have a successful delivery and child. Aaron, I'm going to kind of throw you a question that didn't lead you for, but veterans are a vulnerable population too. What is the Veterans Administration seeing in terms of opioid use among veterans?
Opioid use among veterans was astronomical, frankly. And I'm really proud of the programs that the Veterans Administration developed. Now, I will say that the programs that they developed initially were on diminished initiation of opioids for those veterans in pain. In other words, we have a lot of protocols. If you're going to place a patient on a Schedule 2 or Schedule 3 opioid medication, you really have to jump through quite a few number of hoops. That makes it sound just like burdensome, but it's very educational. The Veterans Administration, our EMR, our electronic medical record, is very tied in with the Florida PDMP, Prescription Drug Monitoring Service. So we physically click a button and it brings up the patient's PDMP. And then we do what's called a storm note. Storm note is strategies to reduce opioid use. It's an interesting acronym, but this note pulls up their history and their other prescriptions and gives them a calculated score of what is their risk of being on opioid. Because of the extraordinary rates of suicide among veterans, the Veterans Administration has also put a lot of money and resources into focusing on those patients who have depression, suicidal ideation, and co-occurring substance abuse. As we've mentioned over and over and over again, you know, those people that suffer from substance use disorder don't see this as a problem. They see their substance use as a solution. And what is their solution? Their solution is to obliviating the pain that they're going through or the trauma that they've encountered in their life, be it from childhood adverse events, to PTSD that they've experienced on deployment. And so really, they've done an incredible job of gathering resources and behavioral health providers for those veterans that come to us. We do still have work to do. We're trying to diminish the stigma as well, even despite those programs, with our healthcare providers, educate our providers on buprenorphine, and initiate buprenorphine on more veterans in the department. It's one of the reasons I was hired at the VA Medical Center at Lake Nona, is to kind of expand their protocols to do that for the patients or the veterans who are seen in our emergency departments.
That's great. Yeah, I know that the veterans in general were hit very hard by the opioid crisis. So it's great to see that they're doing some things. We only have about 10 minutes left. I want to make sure that we get to some of our other questions. This has been such a great discussion. But Captain Blue, so what are some of the obstacles that the Black and Brown communities are facing on the opioid crisis?
Great question. And I don't know you know, all of the answers as to what all obstacles are. But from what I've seen, I do believe the main is the lack of education and trust. As Dr. Aaron was just saying, I was shaking my head, absolutely right, because he mentioned how people have become dependent upon it and see it as a solution. And I've definitely witnessed that. And a lot of folks sometimes think we're causing harm by removing them from the environment or getting the help that they need to overcome what they don't see as an addiction or a drug that's causing harm. So education and trust. And we have to figure out ways to really get inside the heart of the community. And I would tell you, I think we have to start with our young adults. We're seeing a slight increase in younger adults, and my fear is that we'll start seeing these drugs creep more into even our middle school and perhaps even elementary school at some point on a larger scale.
Well, that's scary. I know I've heard Dr. Wohl say before that addiction is a pediatric disease. I know that it can start very young. So we've got some great providers, some great leaders listening today. What would you say to them? What can they do today to help educate, to help reach out to these communities that really need to trust the system better and to really get the education out there?
So, you know, that's really a tough question. It's actually loaded. You know, I was at home earlier and I got about 4 phone calls within 30 minutes of each other, and they're all on my work cell, and they all knew exactly who I was, but they're all spam calls. And it's really sad that when you push out information, we live in a time now that the majority information that's pushed out, folks will trash. They just move past it because they're being overwhelmed and things become a little more diluted. So it's really going to take, in my opinion, more face-to-face contact, people being pointed in the right direction to receive the assistance that they need, and to hear from people that are trusted within the community, such as, again, the clergymen, as well as involving members of our local schools.
I think your point about the clergy and the schools are really important, and getting them involved in the harm reduction that we've talked about earlier today. You know, there's opportunities to get Narcan out to individuals to educate the clergy so that they can educate their parishioners on the importance of some of these harm reduction strategies.
I would also say that, you know, Black and Brown communities have suffered for, you know, numerous years from basically disparities in care, not only disparities in healthcare resources, but disparities in care, and frankly, stigmatizing from providers themselves. I would also say that, you know, there's even studies that Black folks that come to hospitals have had diminished perception of pain from the provider. In other words, the provider is more apt to give pain medications to white folks over Black folks, and this has definitely been documented over the recent years. What that has somewhat led to is there's some connection that the Black communities have not, quote, suffered as much with opioid addiction as white communities. You know, it's even interesting to mention that because this disease process has hit white communities so much, it's not unfair to say that some Black folks feel like, geez, that's crazy. We suffered terribly from a crack epidemic in the 80s, and how were we treated? We were treated with law enforcement and crackdowns and jailing, and Black men were put into jails at skyrocketing rates during the 80s. And now, since whites are suffering predominantly from the opioid epidemic, you know, there is a little bit of frustration from the Black community that we're reaching out so much and we're treating it with empathy and kindness. I will certainly say that some of it is probably due to some degree of institutional racism within medicine, but I would also say that it's also due to some of our newer developments and newer understanding of addiction as a disease process and not necessarily a moral failing. Having said all of that, we are finding that mainly this was a white community's epidemic, but now we're finding more Black and brown folks are suffering from it because of exposure to opioids in cocaine supply, in some of the stimulant supply. And just as Captain Blue mentioned, you know, adolescents now, Black adolescents are being exposed to opioids as well. And so just the recognition that this is not only a white person's disease, that this is affecting minority communities. If you look at the rates are really increasing precipitously in the Black communities, and just educating providers on that basis will actually have us open the conversation more to Black folks that are coming in to our emergency departments and hospital settings. So I think the paradigm is definitely changing, but it's going to take a lot of effort.
Yeah, absolutely. And I think that is exactly what we have seen. And there's so much history, just as you mentioned, that needs to be addressed and overcome. I want to make sure that we get to ask Dr. Carviner the same question. So what kind of obstacles are there in women and children who are also suffering from the opioid crisis?
Like all underserved populations, there is the stigma by being young and female and being pregnant, isolating people from any other type of care, because pregnant women tend to be told when they're pregnant they can't go to any other doctor, so they've got to go to an obstetrician. So you're counting on the obstetrician to be holistically evaluating and doing SBIRT. When it comes to, say, women of color, I cut my teeth on the crack and cocaine epidemic in Anacostia in Washington, D.C. in the 80s and 90s. And so I know how culturally isolated that was. But the generational memory from that is widespread throughout the United States. And in our area, in Volusia County, my patients who are African American do have very recent memory of how poorly they were treated during those epidemics, their family members and such. And they're less likely to self-report about opioid use disorder, any kind of struggles, domestic violence, financial, mental health. It is much more difficult for me to gain the trust and rapport with my patients because of that generational memory. And it's my obligation to try harder and gain that rapport. So it's an obligation on the part of every caregiver to recognize disparity in healthcare that is directly impacting their ability to establish rapport and care for people now and overcome that with an extra effort.
Yeah.
So, you know, my population has all of it: youth, being female, also being racially diverse, and being pregnant. That puts you at about as many reasons people don't always listen to you as there are out there.
Absolutely. The stigma is just terrible for a mother, quote, using, you know, and I even see it in providers, and I'll hear nurses comment and say, you know, gosh, you know, what a terrible human being to expose her child to that as well. So I think that pregnant women are just at an awful disadvantage for being stigmatized, even above and beyond what we give for normal people that are suffering from opioid use disorders.
Exactly. When they reach out, they're at great risk of being judged and shamed, and that makes them less likely to continue to reach out. And so we have to make sure that they feel a safe environment in their doctor's office, in the hospital, in the emergency room, and in the community.
Absolutely. And I think, you know, we've answered some of these questions, and I know we're running over time, and especially Dr. Carabiner needs to get back to her patients. And I so greatly appreciate our panelists today. And I greatly appreciate the three of you taking your very valuable time to help educate providers on what they can do to help individuals that are suffering from opioid use disorder, suffering from addiction, understanding the changing face of addiction in our community and in our society. So again, a huge thank you to our managing entity partners, the Central Florida CARES Health System, LSF Health System, and the South Florida Behavioral Health Network. Thank you so much for sponsoring our educational webinar series. This is the last of our webinars for this month, but please go to projectopioid.org and watch the recordings of the webinars and see all of our great panelists. And again, thank you so much to the three of you. I greatly appreciate your time, and I look forward to speaking with you all again soon. Thank you so much.
Thank you. Thank you for having us.
Thank you very much for having us.